All right. Good morning. Welcome to our combined Mount Sinai and Elmhurst Neurotrauma Conference. It's my pleasure to introduce Dr. Capinos, who's going to be our speaker this month. Dr. Capinos has been at Mount Sinai and at NYC Health and Hospitals Elmhurst as our director of neurocritical care there since the summer of 2021. As many of you know, he's has an extensive education in neurocritical care, as well as neurosonography, bioethics, neurophysiology. He obtained his MS and his MD in France, and then came to New York, where he completed his internal medicine internship at Albert Einstein, and then moved to California to finish his neurology residency, and then came back to New York to complete his neurocritical care fellowship at Columbia, and then a medical ethics fellowship at Hofstra University. And we're happy to have him here today to discuss basically the analysis and interpretation of ICP waveforms and tailoring ICP based upon TCD waveforms and TCD data. So without further ado, I'll hand it over to Dr. Capinos. This is the QR code that people can use to access and claim your CME. This is approved for 1 hour of CME. And I can show this again at the end, but without further ado, we'll hand it over to Dr. Capinos. Let me stop sharing my screen here.
Am I on a presenter mode, or do we see too many? Is it too small?
We see your presenter mode, like we see like the dual screen setup. Okay. So you want to swap it, yeah.
And now it's bigger, right?
Correct. Yeah.
Perfect. Thank you so much. Thank you, Dr. Hickman, for inviting me to talk to Mount Sinai and Elmhurst at this joint symposium. The topic, as you said, is on ICP treatment and how we can use beyond what the ICP waveform tells us on the ICP monitor, which is usually a parenchymal or an intraventricular ventriculostomy device. What the TCD waveform, the transcranial Doppler waveform, can tell us additionally, or actually before you have an intraparenchymal or an intraventricular device to tell you traditionally, conventionally, what is the intracranial pressure, how you can infer actually even more data than just the ICP by using transcranial Doppler, whether you use it sporadically as a one-spot imaging technology, or even better, when you run it continuously as a continuous TCD monitoring device. I don't have any specific disclosure, no financial ties to any commercializing company that I'm gonna briefly mention during those slides. And I have the relevant board certifications here for the topic of today. The objectives of this talk would be, I hope the audience will gain some knowledge, or at least a reflection on what they conceived about ICP and TCDs, and eventually develop a better notion that compliance matters more than the pressure inside the skull, and that there's diverse modalities that can assess that. And of course, conventionally, we rely on an EVD to tell us what is the ICP, but that there's other modalities that can give you even more information. We can discern also from those other modalities, especially the one that I'm going to talk about today, which is a transcranial Doppler, actually how to select better which therapeutic options we have, because in our armamentarium to treat an ICP crisis, we have actually many different options. And compared to actually the original publications that came actually from France in the early 2000s, I want to go further, and that's something that I've proposed now even 10 years ago, to disentangle the two issues of compliance from the perfusion status. And that's something that unfortunately was lumped together in the early publication talking about the use of TCDs in neurosurgery in neurotrauma. So as I talked about at the a few last Mount Sinai grand rounds, there's many ways of presenting data, and there's evidence, eminence, and guidelines. I'm not going to talk about much of all that, but more much is going to be very anecdotal, actually. Only a few patients when I was at Northwell on which I deployed that technology, and here at Elmhurst, where I continue to, in a non-structured fashion, to do that. But we hope actually to gain traction and do research and compile data on how useful TCDs are in neurotrauma. So it's going to be more anecdotal and not anchored in guidelines. So as Dr. Hickman introduced me, I train in France, but my neurology and neurocritical care training is in the US, and I really actually thank UCLA and Columbia for giving most of my understanding on how to go beyond just treating an ICP above 15 or 20, as well as during my fellowship at NYPH with Columbia and Cornell. That's where I learned the value of using transcranial Doppler to augment our knowledge about ICP crisis and pathophysiology. So as it was mentioned, I trained, now it's starting to be a long time ago. In 2009, I started learning about neurocritical care, and the hot topic was indeed multimodal monitoring. But look at this picture that was published in, I think, the Neurocritical Care Journal in 2009, where you see all those fancy devices deployed to our gravely ill patients and many different windows into the brain physiology. Actually, one that is missing from this, I don't see the TCDs. And I don't see definitely not continuous transcranial Doppler, which I think did not exist in 2009. But we all talk about the EVD and a probe in the brain measuring the cerebral blood flow, the PBTO2, the EEG, intracortical EEG. The Foley got there, measuring, I guess, it's important, the urinary output. But the transcranial Doppler did not make it to that picture. So that tells you a lot that even in 2009, the majority of neurocritical care training and the premier training programs in the nation were actually only seldomly exposing the fellows to the value of transcranial Doppler. And in neurosurgery, there has been, of course, 30 years of publications on the use of transcranial Doppler in neurosurgery. But compared to drilling and measuring with a probe or a ventricular device, the pressure in the skull, that has always been regarded, at least in the United States, I would say, as less valuable, less accurate, and especially because at that time in the 90s, the transcranial Dopplers were not continuous. Obviously, it was not even meeting the criteria for a true monitor, since it was not giving you the ICP on a beat-to-beat, second-by-second fashion. However, when I started my becoming an attending and taking on my first job at North Shore University in Long Island, you had the beauty of having actually many different ultrasound devices, and every ICU, of course, had to have a regular ultrasound to measure, to do echography and duplexes of the legs. So I started using actually TCDs and looking into what was this correlation with the ICP. Is that truly feasible rather than drilling in the skull? And that owed me, thanks to Dr. Ullman and Narayan, to present that data actually to neurosurgeons nationwide at the AANS in 2014 in San Francisco. Then we presented that almost every year, basically. So now it's been 10 years, and I'm going to give you an updated version, and it gets better and better. But I don't have more data, unfortunately, until we build our own database here at Elmhurst and collect prospectively some data on continuous TCDs in trauma. So in 2015, we presented that, and I think it was the en vogue invoke a term to use precision medicine after, I think, the presidential State of the Union saying precision medicine is the new term that we should use. And it's true, actually, for ICP treatment, I was saying, like, why are we all blasting mannitol and hypertonic and hyperventilation to our patients, or augmenting the CPP the same way? That does not make sense. We should be way more precise in our treatment of ICP elevation, and TCDs can help you with that. So of course, the American Society of Neuroimaging was excited to have me lay out the ground for some research work to try to advance the role of TCDs in neurocritical care. And I presented that also at the CNS 2017. So that's sort of a disclaimer also of the fact that 70% of those slides have already been shown, and it's been already 10 years, unfortunately, that have been speaking about that. And without great traction, I don't know, TCDs is not sexy enough, I guess, for neurocritical care fellows to see value in it compared to probing the brain with invasive monitors. So what were my key messages? They have not changed, actually. In 2013, when I was learning how to do TCDs on TBI and other patients that did not have a probe in the brain measuring the ICP, I was trying to send those messages here through all those different presentations nationwide. Of course, when I speak to neurosurgeons, I'm always starting by saying, no, don't worry, I'm not going to try to convince you that TCDs will replace anytime soon an ICP monitor, whether it's parenchymal or ventricular. However, I want to try to shine some light on the fact that there's a body of knowledge that you can gain, that ICP is not the holy grail. It's not the end for all of better management of mass effect in the brain. When you think about it, the pressure goes up only in a late fashion, and compliance early on can tell you when something is wrong in the skull of your patient. So compliance to me is more important than the ICP value, and definitely the mean value that is displayed and that has been held as thresholded at 20 or 22 for more than 5 minutes and unprovoked as definition of a crisis that we need to address. Actually, before the crisis, maybe earlier on, it would be quite smart to apply something to prevent the crisis, and therefore measuring the compliance more than the pressure elevation would be valuable in daily clinical care in neurotrauma. So the pressure monitors, when you have a probe in the brain that measures, or an EVD, very traditional ICP waveform, my message is in 2013 was like, it's time we stop looking at the ICP mean value of 15 or 20 or 22 being a threshold for treatment. How about we start looking at the P2 being higher than P1? We all learned that in neurocritical care fellowship and in neurosurgery residency, right? That a P2 higher than P1 is bad. So why it never made it to all those guidelines of like, look at that and treat accordingly. Now, in 2013, there was already publications by UCLA, Dr. Vespa and his army of mathematicians and informatics personnel who was looking at the waveform, the entire analogical waveform of the ICP monitor or the ventriculostomy ICP waveform, and transforming that into actually some super fancy calculations of the slopes, the upslope, downslope, the angle, the relationship of P2 to P1, P3 also, and doing area under the curve compared to the slope. It's extremely complicated. We also had, as we all knew in 2009, many data from correlation coefficients, the PRX being more valuable than the ICP alone, and indeed being premonitory of those ICP crises. So we can go all fancy and more advanced, but I was surprised that most neurosurgery residents and attendings would not treat just a P2 being higher than P1 and would wait for an ICP crisis of 20 or 22 for more than 5 minutes. And so where I see also value is if you use ICP monitors, go ahead and at least think about compliance with that waveform analysis. And if you use TCDs in conjunction with the ICP, or when you only have TCDs instead of a probe in the brain measuring the pressure, you can also infer about the compliance and the perfusion status of your patient. So we can use more TCDs on neurotrauma or even regular ultrasound machines, as I said, to infer that compliance issues. So in 2009 and until 2013, when I put up that slide, I would say there was a lot of traction on using a single index called the pulsatility index. And some other body of literature was talking about the optic nerve sheath diameter. I would propose actually to you another index or indices that would be also probably better than just the PI. I would like you to look at it in a way that is not looking only at the crisis and trying to treat it or even detection early of this crisis, but also trying to look at what is the primary issue with your patient. What is the inadequacy that rose that ICP or dropped that CPP? Is it truly the ICP that is too high? There's a low compliance of the brain, or is it a low CPP, a low perfusion status without an ICP elevation? Or is it both together that are injuring our patient's brain physiology at that time? Or is that that my patient has actually nothing wrong with their ICP or CPP? So I was saying that if we use TCD, actually, we can segregate patients into all those different categories, 4 categories of statuses of the complex physiology of their brain in terms of at least 2 parameters, 2 domains, compliance and perfusion. My key messages at the ANS also, because usually I cannot get the attention of people to pay attention to that novel technology that is called transcranial Doppler for too long. I was saying, if you remember only this slide, it would be this. Please use TCDs for those purposes. Prognostication in the ED of your TBI patient, TCDs can predict upon arrival in the ED if your patient will be more likely to have death and poor functional outcome after TBI. That was a neglected almost body of literature that came from France. Dr. Viguet, I think he's an intensivist, but extensively working in the Department of Neurosurgery at in Paris at the Kremlin-Bicêtre. And the triaging for the decision subsequently of going to an ICU and definitely probing the brain with an EVD or an ICP monitor could be done by TCDs. His colleague Racht, I think also in Paris or in Toulouse, was saying we can at least do a triaging with our TCDs, then subsequently a probe will go in the brain with our colleague neurosurgeons. So that was published by Racht and Viguet, and I'm going to give you those references later. What I was trying to go even further with was those 3 other statements that you see on that slide below. So in 2013, I was saying beyond what Viguet and Racht have published in the early 2000s, we can also use TCDs in neurotrauma to do the following. We can use it because it's non-invasive and it can help you with the following. Teasing out better if your compliance or your perfusion or both is what is problematic with your patient. We can do an earlier detection of an imminent crisis when we see the trend of the compliance being altered or the trend of the CPP going down with the correlate that I'm going to give you, the biomarker on TCDs. And then we can allocate the specific treatment. What is wrong with my patient? My patient in bed 1 at 3 p.m. has more of an issue with his ICP going up, but the same patient 3 hours later might have an issue more with his CPP being too low. So which one should I try to address? And of course, our armamentarium of treatment is different and can address the primordial issue. So in 2013, I was also in the aftermath of this huge controversial publication that revolutionized the way we address multimodal monitoring, actually, which was this BEST trip trial, right? So we're all familiar with the results, and basically it was saying that clinical radiological management can be equivalent in most cases to an EVD-guided treatment for the ICP. What did it mean? And there's many editorials and vigorous pushback on the misinterpretation that many got that, oh, we don't need EVD, then ICP doesn't matter. No, it's not at all with the conclusion of this, what Dr. Chestnut and others have been pushing as a proper interpretation of their of their randomized clinical trial was that actually just looking at an EVD ICP and treating it is maybe not enough, and we should go further than just looking at the ICP thresholded at 15 or 20. Because otherwise we don't do better than when you don't have an ICP and you just look at the clinical exam and the badness of the mass effect on the CAT scan. So it's not that we got it all wrong with the EVDs in North America and in Europe. No, it just meant that we are inadequately thresholding or interpreting our ICP. Should it be that we abandon ICP? No, but as an adjunctive tool, we should look at other ways of informing our decisions for treatment. And in 2010s, in the early 2010 years, we were also having a flurry of publication about starting to use TCDs, but it fell out of favor because of all this negative correlation to the subsequent ICP value. So in 2010, where the groups that were still trying to promote a better understanding of the ICP waveform was also coming from Chosnica and others, and saying that actually the waveform should be interpreted in an analogical way rather than just a number. And I will refer you to these publications like this one, talking about pulse amplitude and other measurements. And in 2013 or 14, when I interviewed, at least I did a quiz in the audience of mostly neurosurgeons, and I was asking them which waveform would you treat out of those 4 scenarios right here. It was a little bit of a split. Obviously here the compliance, I don't know if you can see my cursor, I've been told no. So, but anyway, the one that says on the top left, 5 and a beautiful waveform, very compliant, this is definitely, nobody's gonna treat that. There's no crisis and there's no compliance issue. But the one that is on the top right is also, sorry, the one on the top right is actually challenging because it's normal compliance, but the mean is at 25. So here it would be about 50% of neurosurgeons that I interviewed were saying, yes, I would treat just the waveform, just the mean value being so high at 25, even if the waveform is telling me that my patient is compliant. Bottom left, we have a very poorly compliant. You see the P2 is super high and the P3 is even higher than the P1, but the mean value is only 5. Would you treat that? Same thing. It was really a split. Some neurosurgeons would treat that. Some others would say, no, ICP 5, there's nothing wrong with my patient. And finally, the bottom right is straightforward. The ICP value is 25 and the waveform is abnormal, so everybody would treat that. Here is a snapshot of a patient of yesterday morning in our ICU. And I'm not going to tell you what the CT shows, but look at this waveform. At first sight, it's actually up and down, and you would say mean value of 15. It looks good. The slope also, the angle, right, the sharpness is quite high. So actually it means usually normal compliance. But I would like to point you, without a cursor, it's going to be hard, but look at the little dichrotic notch that you can see there. It's not dichrotic, but you see that little notch on the way up, the slope. That's actually telling you that the P1 is low. And then that big bump that you see on top, the peak, is actually the P2. And then we see also the P3 on the slope down has a little notch there. So there's actually 2 notches. On the way up, a notch that tells you that the P1 is low and the P2 is super high, twice the height of the P1, and the P3 is also higher than the P1. This patient has a mean value of 15, but I guarantee you, if I showed you the CT right now, she progressed to brain death with global cerebral edema, hydrocephalus, IVH, modified Greb up to the max. So frankly, this is a patient that has a big compliance issue, and the ICP should be considered catastrophically high in that patient, even if the mean value is only 15. So pay attention to those little notches that will reveal to you that actually the P2 is super high. And you can hyperventilate. I have a video, but I don't have time to show that. It will definitely dissociate this little notch that you see on the way up of your slope. And here the CPP is, look at 10 a.m. when I took the picture, 75 of MAP minus 15, 60. So everything is honky-dory. RCPP 60, wonderful. ICP 15, wonderful. Yet the CT was catastrophic. The clinical exam was near brain death. So don't be fooled by the numbers. Please be perspicacious at looking at the waveform rather than just looking at numbers. We all know what P1, P2, P3 is, and we can complicate the interpretation by looking at the pulse amplitude, pulsatility index, resistivity index, and as I said, UCLA in the early 2000s was even developing fancy mathematical models of the different slopes, telling you about the vasodilatory and vasoconstrictive state of the patient's capillaries. But actually, that goes above my head here. I put a few pictures of the original publication of Mokaip from UCLA, but as I said, Dr. Vespa is way brighter than me, and he has an army of mathematicians publishing every month in IEEE journal about new models and new devices. I think, at least in 2013, what I was trying to tell neurologists, neurointensivists, and neurosurgeons is you don't need to wait for UCLA to commercialize their new devices or doing the math yourself for this, but at least, please, let's start with, can we treat with osmotherapy or an augmentation of the blood pressure every time our patients have a P2 that is significantly higher than P1 in the correct, of course, clinical scenario. I think Mokaip goes beyond what an ICP crisis is. It was telling you about the compliance, sure, but also, as I said, the vasodilatory versus vasoconstrictive state of the capillaries of those patients. And it also assesses the cerebral autoregulation. Going back to very basic things also, not as fancy as UCLA, we had what neurosurgeons were already using, as I said, in Paris and in Toulouse, in France, in the early 2000s. Actually, the first publication of, I think, TCDs in neurosurgery was in the late 80s. And definitely in the 90s, I can tell you that there was a lot of triaging that was occurring. And finally, this landmark paper was actually in the journal Neurosurgery, I mean, the French journal Neurochirurgie in 2008. And Paris and Toulouse together published their cohorts of patients in which they were using TCDs to triage severe TBI in the ED. All those patients subsequently got an EVD, but they were saying, can we detect which ones will really be high on the subsequent ICP placement and on the subsequent ICP value once they have a probe in their brain measuring that. So sorry for the French here, it says VD, that stands for velocity diastolic. So the other term that we use in the American literature is end diastolic velocity. So when the end diastolic velocity was below 20, or the pulsatility index was greater than 1.4, they were saying those severe TBI in the ED definitely were referred to the ICU with neurosurgical care and placement of an ICP monitor. So it was a triaging tool, basically. They were using TCDs. And I was like, is he using a normal TCD machine like I'm used with those little probes and you do just a B mode? No, actually, sorry, an M mode and you do regular TCDs. Dr. Viguet in France was already using actually TCCDs, transcranial color duplex. And that is beautiful because actually you see the circle of Willis, you can see here, and you can insonate you can see your angle. But anyway, even if you're a poor sonographer, just making sure that you're picking the MCA, you're going to get a pulsatility index. And the beauty of the pulsatility index is that because you're doing a ratio, you're removing the cosinus of the angle. So even if you're wrong and you're almost 90 degrees in insonating your MCA, your PI will still remain valid because you're removing the angle because it's a ratio. So the good thing about the PI is that the angle doesn't matter. And the good thing also about the cosinus is that you're only underestimating. So if you're picking up a velocity and it's above 20 and the end diastolic velocity, you know that this patient is definitely having at least an end-diastolic velocity above 20, if not higher. You're never underestimating. So it is a problem when you're measuring for vasospasm, because you want the true velocities and you're looking for a high velocity. But here, because I'm looking for the end-diastolic velocity being at least adequate above 20, it's perfectly fine that I am a poor sonographer, and with a terrible angle, I will always underestimate. And therefore, if I see one value above 20, I know my patient is perfusing well. I'll give you the data on that. So this is our pictures from North Shore in 2013, where I was not as good as Vigay, but I could see the circle of Willis on most of my patients. And here is the waveform that you can see with the peak systolic velocity right there and the end diastolic velocity right there. And you can see it's above 60. So this patient was quite perfusing well. So the Gosling PI was quite frequently used in the literature in the 2010s. But I would say I agree with the neurosurgeons that were pushing back at that time against the overuse and oversimplification of using just PI instead of an ICP. Actually, it's not well correlating. It's true to the subsequent ICP monitors, the value on of the ICP on the EVD. There's two publications in 2011 and 10 by those two groups, including one famous neurosonologist, Dr. Razumovsky. I think he was at Johns Hopkins with Dr. Armonda. And together they said, you know what, actually it's true. PI is not that great. It does not correlate really well to the ICP monitor. But what I would say against that is that we're looking at the wrong gold standard. Is the gold standard really the ICP, the pressure inside the brain? Or is our gold standard measuring more the compliance? I would actually suggest that it's the compliance. So it's as weird as argumenting to a cardiologist, well, the ST elevation on my EKG or depression does not correlate to the burden of infarction in the heart upon completion of the infarct. Well, yeah, because it's an early detector. Ischemia does not make infarction, doesn't mean infarction. Compliance abnormality does not necessarily mean that subsequently the ICP will go up, but it's an alarming, an ominous, a premonitory sign that tells you that something could go wrong. So I think all those publications that decried the value, or how do you say, diminished the value in the literature of PI was only because he was comparing it to ICP gold standard with an EVD or an intraparenchymal monitor. And I would disagree with that, because I would say that's the wrong gold standard. I'm not claiming that TCDs tells you the ICP. I'm claiming that TCDs actually tells you more than the ICP, something that is more important. Furthermore, it can also tell you two separate things. As I just tried to make you pay attention to, the PI is one thing, but the end diastolic velocity is another. I know Vigay put it together, and Racht and Geertz in France kept publishing about, let's look at either or. Either the PI is high or the end diastolic velocity is too low, and whatever is going on, that's bad. Well, I was saying we should go even further. I think there's value in doing TCDs and separating those two issues. If my PI is abnormal, it means that my primary issue is truly that the ICP will subsequently go up. The compliance is very altered. So the brain is tau edematous. There's something inside the skull that makes the compliance go down. The ICP will subsequently go up. That is a bad thing. What is the treatment for that? CSF diversion, remove that tumor or the blood, the hematoma in the skull. Do a craniectomy for decompression. Do osmotherapy to shrink the brain. Versus when our end diastolic velocity is too low, it means that the issue is more the CPP will be too low. It's inadequate low perfusion of the brain, and therefore the treatment should be elevate your MAP. If you do osmotherapy, probably mannitol would make more sense, because it will also plump up the volume and elevate the MAP subsequently. And you can therefore individualize the treatment of the ICP crisis based on the PI versus end diastolic velocity abnormality. Furthermore, an issue that has not been emphasized enough, and I learned that from Stefan, that Dr. Mayer, that has been quite instrumental in the early 2010s to put this other waveform that nobody keeps in mind. We're all about this red line right here that we all saw, which is the autoregulation, right, with the cerebral blood flow maintenance at diverse levels of CPP and therefore the map. However, when you think about it, when you're in a vasodilatory cascade, your ICP will also go up. And therefore, when you are in a vasodilatory cascade and your ICP really surges, probably basically a significant crisis, with a low map, the perfect treatment for it is actually a norepinephrine push, because that will elevate your CPP. So you're going to go back to the middle of the graph right here, and you will decrease your ICP along with it, because as you see, the yellow slope will go down. And thus, you will catapult your CPP. You treated both a CPP issue by elevating the map, plus you lowered the ICP. Therefore, the CPP got significantly better because you moved the two needles in the right direction. So your CPP will be significantly going back into the physiological range. And when you think about it, that's what Mother Nature does, right? When you have an ICP crisis with a plateau wave, you have suddenly stress, and the heart will suddenly pump higher blood pressure to try to restore the map and get you out of this horrible crisis that is in a vasodilatory cascade. So the two schools of thought, I know I'm a little bit too categorical or caricatural, but basically all those publications by the Loon School of Thoughts that the ICP is so primordial. Who cares about the CPP? Always treat an ICP above 20. I will call that the Loon School of Thought. Versus what Claudia Robertson tried to push later on was actually that in 1999 was that the CPP adequacy matters more than what the ICP is. Sure, try to fix your ICP, but if you cannot, you need to press your patients to restore at least a decent CPP above 60, since it's linked to an amelioration of the outcome or getting them out of a poor outcome when you maintain the CPP above 60. So those two schools of thoughts could fight, like, should I treat more my ICP or my CPP or always do both? Well, actually, I think it's a false debate. Because now, if you look at TCDs, you can decipher which patients have more of an issue with their ICP versus more an issue with their CPP, or both. So which parameter on TCDs will tell you really what is going on with the CPP? So the PI is high for both the ICP going up or the CPP being too low. And many people have said that is why we love the PI, because the pulsatility index of Gosling will go up also in the vasodilatory cascade. That is true, but its sensitivity to detect an ICP elevation is not that great overall, because it's detecting it once you're in the middle of the vasodilatory cascade. So in 2013 and 14, I think I was studying for my boards of neurosonology to become a registered physician in neurovascular interpretation. So all the books were quite old, actually, from the 80s and 90s with Dr. Wexler and Babikian, telling you that actually there's an entire body of literature supporting that the CPP decrease is very well detected sensitively by your TCDs with a waveform with, sure, the pulsatility index goes up, but it's because of the drop, as you can see, in the diastolic velocities. So when your velocities go down in the diastole, the end diastolic velocity goes really down, the systolics remain the same, and that is why the PI goes up. The PI goes up because the end diastolic velocities goes down. And actually, the magnitude of decrease in the end diastolic velocity correlates better to the CPP adequacy. Another paper that, going back into the 80s, that piqued my interest was the fact that everybody was saying the diastolic velocities are going down when your CPP goes down. And I was like, that's actually a slope that is more sensitive than what the mean flow velocities will tell us. Chosnica, Kirkpatrick, and others also have said that the diastolic velocity is going down is the problem. Oh, so here we don't see what I wanted to show, but that's fine. I'll skip to that slide. where it shows that if you had to pick between a cerebral blood flow measurement in the brain, peak systolic velocities and diastolic velocities, or the PI, which one will linearly correlate to a drop of the CPP? I'm sorry, you don't see the bottom. It says below 60, and then it goes into the 40s. The linear correlation is with the end diastolic velocity. So all the fuss and the publication that has been going on in the 2010s about PI, to me, was a little bit weird. We should have been paying also attention to the end diastolic velocity. And that is why I was proposing that we can resolve the issue of this debate of, is the ICP more important or is the CPP more important? Both are important in different patients. And so going back to what Vigay was doing, he was saying, well, I don't he did not disentangle. He was looking at the end diastolic velocity being too low or the PI being high, or the end diastolic velocity being decent, but the PI being high. He was telling you, I'm more worried about all those patients, and I will deploy actually almost the same treatment for all of them. So I wanted to actually go further than what they did, because I think the treatment should not be the same. But yet, I want you to see those publications about the fact that actually it's true. TCDs in the ED upon arrival of a severe TBI correlated subsequently to the placement of an ICP monitor. The patients who were with a low PI had actually lower ICP subsequently. They were 22 as opposed to 32 in those that had a PI of 1.4 as compared to 0.9. And the diastolic velocities also predict that, because the diastolic velocities are better, 36 in the patients who will have a normal ICP versus the patients who had a decrease in their velocities at 25 had actually a higher ICP subsequently. So this was TCDs in the ED correlation to the subsequent ICP upon an EVD placement in the ICU. They were looking more, not at the treatment, but more as a triaging tool and also prognosticating. Like, can we know if the PI is higher or the diastolic velocity, if they're going to die more or have a poor functional outcome, ascertained here by the Glasgow outcome scale at 3 months? And the answer is yes. Of course, people who were with a high PI and a low diastolic velocities were dying more. People who had only one out of those two abnormalities were dying a little bit less. And finally, the best category was to have normal diastolic velocities and normal PI. The good outcome was prominent in that group of patients. But yeah, prognostication, I'm not too keen on that. I wanted to focus more on the treatment aspect. And that is why, as I said, in 2013, we proposed the following. When your PI is low and your end diastolic velocity on TCDs is high, above 40, and I can explain to you why I went up from 20 to 40, you know you're compliant, your brain is compliant, well perfused. So continue whatever you're doing. You don't need to tweak your meds, don't tweak your ventilator, and maybe those patients could go to an intermediate level of care or observation, not an ICU. That goes along with what Vigay and Racht and Gerhardt were doing in France in 2008. When your PI is high, it means truly you have a poorly compliant brain, but it is well perfused if your end diastolic velocities are above 40. So what do you do for that? Treat with osmotherapy with maybe mannitol would be better than hypertonic. You can use mannitol because the volume of your patient during the diastole is telling you that they're perfusing well. So you have room for dehydrating a little bit your patient. You can consider mild hyperventilation. That would make sense, right? That will reduce the issue of an ICP elevation. And you can mildly decrease your MAP. You have room because your patient is perfusing during the diastole quite well. But the patient is at risk of deterioration, therefore, at least they should go to a neuro ICU. When your end diastolic velocity is low, it means you're hypoperfusing your brain. So in the patients who have normal PI, but dramatically low end diastolic velocities, the primary issue is the hypoperfusion. So here, what are you going to do? You also treat, but you should not use osmotherapy. That does not make sense. There's no issues with compliance. But if you do want, because your patient is then subsequently herniating in front of you, you can use that category of patients to select the hypertonic rather than the mannitol, because at least you will plumb them up and restore better diastolic flow to perfuse the brain. If you had to pick something on your ventilator, those kind of patients should be hypoventilated, maybe to ameliorate the cerebral blood flow by elevating the cerebral blood flow during the diastole. So permissive hypercapnia would be a logical deployment of allocation of treatment to those patients. And definitely you can quickly raise the MAP, because the issue here is the perfusion of the brain is very poor. When your patient has both the PI being high and the end diastolic velocity being low, then you have a poorly compliant brain that is not well perfused. What you need to do is osmotherapy. Definitely hypertonic makes more sense than mannitol. You can do normal ventilation because you have no room. Actually, you cannot hyperventilate. You're going to worsen their diastolic perfusion. And definitely the main treatment should be, along with your hypertonic, to raise the MAP, but it should be raised slowly. Otherwise, if you raise it too brutally, it's going to go with the PI also elevation. So you see the categories, which resembles, I think it was endorsed subsequently. It's the same as what the Boost does with the PBTO2 versus ICP. Here, I'm saying within the ICP, there's also value in looking at is it a CPP issue or is it an ICP issue to deploy the most appropriate therapeutic options. We did that. I'm going to skip because it's very anecdotal, only a few patients. We did that without an ICP monitor on a few patients at North Shore in 2013. One had hepatic failure, coagulopathic. Nobody wanted to put an ICP monitor on them. So I used TCDs because of the global cerebral edema to guide our management. One had meningitis also, global cerebral edema, and an intraparenchymal hematoma. So the neurosurgery group did not want to put any probe in the brain. It was at risk of bleeding too much. One had a TBI, moderate, no surgical lesion, and compensated DIC. So because of the DIC, though, Dr. Narayan's team did not want to put an ICP monitor or an EVD. And finally, we had two large hypertensive intraparenchymal hematomas with mass effect that were also not meeting criteria for an EVD or an ICP monitor. I managed them with the TCD, and we looked at the outcome. I applied my therapeutic choices along the 4 categories that I give you in the table, and we measured if the trend of the TCDs were going towards an amelioration or a worsening, or if I harmed the patient with a worsening of their neurological status. One patient fell under the green category. 2 patients were in the red with everything, the PI being high and the end diastolic velocity being low. One was in the orange because of an issue with their ICP, and we addressed that specifically. And one patient was in the category of having poor perfusion, and I elevated the perfusion without raising the ICP. All patients had normalization of my parameters with a trend over hours within our target range, thanks to the tailored therapy that they deployed to them, and no patient had a neurological worsening. I think using that was still judicious, and at least it was feasible and not harmful. Outcome, though all those patients, as you saw, were even too sick for neurosurgeons to even put a probe in their brain, so they actually all died except the TBI. So PI and waveform analyses are more important than just the mean ICP. The compliance is a better gold standard to me to decide on osmotherapy rather than waiting for a crisis. TCDs are easy to use, and they can predict and detect early an ICP or a CPP issue. And what is even more important to me is that then we can disentangle those issues. Is it truly the ICP that is going to be high, or is it the CPP that is inadequate, and therefore you can tailor your treatment? Those 4 categories, to me, deserve a real feasibility study, and then we could even submit a grant to really randomize our patients to the classic treatment, which is what I would call a monolithic ICP therapy treatment. ICP is high, therefore you deploy both osmotherapy and MAP augmentation. CPP above 60 and ICP below 20 equals good outcomes. Well, I would challenge this monolithic view, and I would say maybe we can be more fancy and deploy one of those 4 categories of treatment to our patients. And we'll see if the outcome gets better in my 4 category treatment versus the conventional treatment. We already talked about that, but I would say that actually, let's not stop there at TCDs. There's value in complementing our evaluation of the physiology, the arrangement of our patients with near-infrared spectroscopy, jog board, the Tickner shift diameter, Hemidex, And now we have also on the Hemedex a measurement of the amount of water that you have in the brain. We could ameliorate also the PI and the RI and use MoCape from UCLA. I want to thank people who really inspired me over the last well, I haven't done much over the last 10 years on that front, but originally in 2013, I want to thank Dr. Chosnika for the few discussions that we had together in Europe. And then actually I discovered that the RI, the resistivity index, which is the difference divided by the systolic instead of the difference divided by the mean, was invented by actually my own teacher of neurophysiology or even physics in Tours in my medical school. I cannot believe that we had such a prominent physician and physicist at Tours in the Loire Valley in France. He was actually working for the NASA, and a huge name that invented this resistivity index. To give you a few publications that are super old in the neurosurgical world already embracing the resistivity index. Chaddock et al. Looked at resistivity index correlates to the shunt malfunction. So that gave me an idea of using resistivity index during a clamp trial. And Klingelhofer also was looking at the resistivity index as opposed to the PI for deciphering when patients were developing vasospasm versus an ICP issue. So there's ample literature, and we should do more research on TCDs in neurotrauma. I think we can also look at it with a dynamic like the trends and the evolution over time, rather than just the passive MX that has been promoted by Cambridge. We should do more challenges with the breath holding index, acetazolamide or carbogen. I don't have time to discuss the cerebral regulation. I'm going to skip over that and finish by telling you that we definitely need to use more TCDs in neurotrauma. I think it can predict blossoming contusions, early detection of mass effect, premonitory signs of ICP crisis. The trajectory could be followed, and I would say probably we can use that to decipher which patients need to go to the OR for a hemicraniectomy. Intraoperatively, maybe you can use TCDs to look at the swelling, and sometimes you have inability to close because of the severe swelling upon the decompression of those brains. I know every time we talk about TCDs, people focus on vasospasm. So trauma vasospasm, yes, to me it's useful, but even more so, the robustness of the venous outflow can be ascertained by TCDs, and that's quite important to assess in neurotrauma patients. We could look at our response on TCDs when we start to treat our patients with hyperventilation, hypertonic, mannitol, THAM, phenobarb, hypothermia. We can assess also the risk of severe edema and hemorrhage in the brain, and adjust then based on our TCD surrogate values, our biomarkers. We can adjust the gold blood pressure, adjust if we really need to do a monitor in the parenchyma versus ventricular. Maybe we can adjust how much osmotherapy we give, which one, and also anticoagulation. So it's fun. Physiology is complex, but I love to be beyond a plumber, a physiologist, and an imager. And I want to thank Mount Sinai Hospital and Elmhurst leadership for providing us at Elmhurst with our technology that we need to ascertain those patients from different angles. Thank you to all our leadership about the biosignal, which is an EEG technology, and I hope to get soon also continuous TCDs with the NovaSignal device, which is right in the middle right there. And all of this will only make sense if we plug into our Moberg, which is on the right, where we try to look at trends and correlation coefficients. So thank you. Join us if you're a fellow or a resident and you want to go into a fellowship in neurocritical care or in neurophysiology. And please join us also if you're interested in neurophysiological approach to our patients as a nurse practitioner or a PA. We are recruiting at Elmhurst, and I would love to have also TCD and EEG technicians joining our group to do all that research. Thank you.
Great. Thanks, Dr. Capino. That was an excellent talk and overview. I really like the use of the TCD as a as a multimodality device as we currently do at Elmhurst to really tailor the treatment, I think, for those patients that are at risk of even those that aren't necessarily at risk traditionally of elevated ICP, as you mentioned, could benefit potentially from osmolar therapy. Obviously, the the issue is that, many of the studies don't have a ton of patients in it, but it's, one of those things where the only reason we use the mean ICP number is just because that's the easiest thing. And it's just the
Yeah.
tip of the iceberg. There's a lot of data that is lost in only using that in your treatment, or even just the waveform itself, when we should
Yeah.
really be looking at a lot of things. I mean, could even potentially use it. I mean, I'm not sure how useful it would be, but maybe predicting patients that would need hemicraniectomies after malignant stroke
Yeah.
might be useful for that. It might be, but there's both prognostic and management capabilities of TCD, and it would be nice eventually to have a continuous one, like you said, or maybe someday they'll have something like a Cerebell sized TCD thing that you can just slap onto somebody in the ED and it will find the window
Yeah,
for you.
exactly. You're reading my mind. I want actually trimodal, near-infrared spectroscopy and EEG and TCDs. I think the future headband is that. Yeah, you're right.
Mhm. But I definitely think, at Elmhurst, we could certainly protocolize using the TCD and using, particularly, like you said, pulsatility index and EDV to tailor more, just like we would with, PBTO2, to tailor what our response is going to be in terms of treating patients. And like you said, using it for clamp trials or using it to help figure when it's safe to remove our ICP monitoring device or EVD is also going to be very useful. And then we should obviously, I agree, we should develop a protocol so that we can not only do it clinically, but gather data on these patients so that we can add to the research literature on that. Because many of them don't have that many patients anyway.
Yes, thank you so much.
Well, I know we have to go, so I'll leave it at that. But thank you very much. I appreciate you coming out as well on short notice. And this will all be up on the YouTube and our YouTube channel. And again, I'll just share this. This is our QR code that people can scan to claim their CME for this conference. Our next conference is going to be in March, on Thursday, March 23rd, where we will have a visiting lecturer, which will be Dr. Christopher Winfrey from Columbia University College of Physicians and Surgeons. And he will be speaking on peripheral nerve injuries, which is a topic we haven't touched on in this conference yet. So we hope people will join us for that. And again, thank you, Dr. Kapinos, and appreciate your talk.